My name is Chris Dimmick, and I'll be moderating today's webinar. I currently serve as the Director for AHRQ's Digital Healthcare Research, or DHR program, which is part of AHRQ's Center for Evidence and Practice Improvement. DHR's mission is producing and disseminating evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. To fulfill this mission, the program funds research that yields actionable findings around which digital healthcare technologies can improve care for our key stakeholders, patients, clinicians, and health systems. We'll discuss 3 of these exciting research projects during today's webinar. Next slide, please. Here's the agenda for today's webinar. Please note that we're recording the webinar and that the recording and slides will be available on the DHR website in a few weeks. You'll be notified by email once they're available. Next slide, please. Pleased to have with us today an esteemed group of presenters. These include Dr. Jinoos Yazdany, Dr. Margie Snyder, and Dr. Stephen Dehmer. This webinar is accredited by Affinity CE. If you're interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For purposes of accreditation, let me note that AHRQ, SD Solutions, and Affinity CE have no financial interest to disclose. Dr. Snyder and Dehmer also have no relevant financial interests to disclose. Dr. Yazdany has independent research grants for Gilead, Aurinia, and the Bristol-Myers Squibb Foundation. She also participates as a clinical trial site for AstraZeneca and is a consultant for Pfizer, UCB, and Impact Bio. Please note that no commercial support was received for the development of this learning activity. Next slide, please. So just a brief note about questions. We've reserved time at the end of the presentations to address our participant questions. However, during the presentations, please feel free to submit questions that you have for the presenters using the Q&A panel located to the right of the PowerPoint slides. Please include the presenter's name or their presentation order number, first, second, or third, with your question. As a reminder, participants are in a listen-only mode, so to ask questions, you'll need to use the Q&A panel. Next slide, please. Slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to explore the process of spreading and implementing patient-reported outcomes across rheumatology practices nationwide, shedding light on the practical aspects of this journey. Explain the benefits and challenges of using a mobile application to collect PRO data on medication adherence in pharmacies, and discuss patient preferences and how PRO measures are collected and used in orthopedic care, and how they may be used to enhance shared decision-making and improve outcomes. Next slide, please. And now it's my pleasure to introduce our first presenter, Dr. Jinoos Yazdany. Dr. Yazdany is Chief of the Division of Rheumatology at San Francisco General Hospital and the Alice Betts Endowed Professor of Medicine at the University of California, San Francisco. Her scholarship focuses on improving healthcare quality, safety, and outcomes for individuals with chronic rheumatic diseases. She directs the NIH P30 Clinical Data and Informatics Core at UCSF and is the research lead for the American College of Rheumatology's RISE registry. So, Dr. Yazdany, we're turning over the control to you. Thank you.
Thank you so much. Such a pleasure to be with you to talk about rheumatoid arthritis and patient-reported outcomes today. So I'm going to try to share with you 3 key questions our research has tried to answer over the last several years. First, can we scale and spread the use of RA PROs across U.S. rheumatology practices? Next, can we extract this PRO data from our registry and EHR data? And as a corollary to that, can natural language processing, or NLP, of clinical notes enhance that information extraction? And then finally, can we develop implementation tools to help practices collect and effectively use RA PROs to improve care? So first, just a little bit about rheumatoid arthritis. RA is an autoimmune disease that can destroy joints and lead to disability if untreated. And RA is actually not rare. It impacts about 1% of Americans. And the main goals of RA treatment are to reduce disease activity and also to preserve function. And disease activity often is measured using patient-reported outcomes. Alternatively, we measure it using a composite measure that accounts for tender and swollen joints as well as a patient-reported component. And then physical function is measured using PROs. And these are the ways that rheumatologists sort of track disease outcomes over time. And in our field of rheumatology, we have been using PROs for a really long time. Notably, in 1980, the Health Assessment Questionnaire, or HAQ, was introduced. And since then, we have several decades of experience in terms of using these PROs in practice and also generating evidence about their utility. So we have actually randomized controlled trial evidence that suggests that using RA disease activity measures to treat to a target of low disease or activity or remission in RA actually leads to less joint damage and less disability. It improves patient outcomes. And then in terms of functional status PROs, they aid in the detection of functional decline and also enrich shared decision-making by capturing the patient's symptom experience. So let's start with the first question. Can we scale and spread RA PROs across U.S. rheumatology practices? So building on the decades of PRO measure development and validation, in 2012, I and others at the American College of Rheumatology actually sifted through all of the PROs that were available in RA. And this was actually, quite a task. There were over 60 measures that we reviewed related to disease activity measurement. And we picked the ones that were the best of set, those that were valid, reliable, feasible, and basically made recommendations for their use in clinical practice. That formed the basis for the development of quality measures, which went through the National Quality Forum's endorsement process and were entered into quality programs through the Center for Medicare and Medicaid Services. The measures were also built into our national registry, which is called RISE, and I'll tell you a little bit more about that in a moment. And then more recently, with funding from AHRQ, we have been working to extract these PROs from our registry for federal quality reporting purposes and also for research, and then developing tools for practice to really optimize their use of PROs. Let me tell you a little bit about the RISE registry because it's been very critical to performing this research. RISE is the American College of Rheumatology's Qualified Clinical Data Registry. It collects electronic health records data from practices across the country. About 1,000 rheumatologists participate, which is just under a third of our clinical workforce in the field. And at this time, there's 3.2 million patients represented in this registry, and they have 34 million collective visits. And you can see that there's pretty good geographic distribution of these practices. Most of these practices are community practices, and we collect all structured EHR data as well as clinical notes, and then practices can access a dashboard where they can view their performance on quality measures, including PRO-based quality measures, and report data to CMS. And then the data is also aggregated for research. So let me show you some data from the RISE registry. This is one of our disease activity quality measures that has a PRO component to it. And you can see in this figure that our registry, which started in 2014, has been measuring this quality measure related to collection of disease activity. And there's been a steady increase over time and sort of a leveling off at around 60% in terms of performance on this measure. And interestingly, we don't see major differences in performance by age, sex, race, ethnicity, or socioeconomic status. Really, the gap in performance is based on practice variation and some practices just not having the ability to put this information into structured EHR data. In terms of functional status measures, performance in the registry is similar. We have about 60 to 70% of the time these measures being collected. What's interesting is that, at one point we have performed manual review of EHR clinical notes, and we find that actually there's even more PRO data there. And so the structured data is capturing about 60%, but we're up to about 80% of this data being collected routinely in clinical care. And this really consensus-based PRO recommendation and the RISE registry has really enabled a national system for doing research based on PROs. And this is just one example of the types of studies that have been done. So in this study, we were interested in looking at differences in functional status outcomes in people with RA by socioeconomic status. And we used the RISE registry and data from over 80,000 people with RA to demonstrate really a gradient of functional status related to socioeconomic status, even after adjusting for other factors, really demonstrating a health disparity. And this really demonstrates how PROs in RISE have facilitated a national system to monitor health disparities and to begin to test interventions to address populations that are at risk for functional decline. So to answer this first question, can we scale and spread the use of RA PROs across U.S. rheumatology practices? Hopefully the data that I've shown you demonstrates that the answer to that question is yes. People with RA now have PROs measured at a majority of U.S. rheumatology visits. And some of the key lessons that we've learned in our field is that professional consensus on which measures are valid, reliable, and feasible in clinical practice has really facilitated a cohesive national PRO collection strategy. Second, the development and endorsement of quality measures incentivize participation by rheumatologists. And third, the registry technology infrastructure has facilitated performance feedback, research, and quality improvement. All right, so on to the second question. Can we extract this PRO data from the registry, and will natural language processing increase yield? One interesting thing, as we've done this work over the last several years, is just observing that rheumatologists are currently recording PRO data in many different places in the EHR. Some are recording it as a vital sign, some are recording it as a laboratory value, others are recording it in a nursing flow sheet. And so normalizing that data to extract it for quality measure purposes has been important, but feasible. In another project, we were very interested in understanding whether or not NLP could really enhance that information extraction for PROs. And so working with a team of computer scientists and NLP experts at Stanford, Suzanne Tamang and her group, we developed an NLP pipeline using expert curated terms and spacey text processing to basically extract 8 RA disease activity and functional status measures from the RISE registry's clinical notes. And in terms of methods, we evaluated the NLP pipeline by performing chart reviews, comparing what we were getting out of the notes to the structured data that we had in the registry, and then performing an external validation in another health system that was not affiliated with the registry. And I'll just pause here to say that, the bulk of the work for this project was just, getting all of these notes aggregated, working through the IRB permissions, removing identifiers so that the notes could be used for research, and then cleaning the data. That really was an enormous amount of work. But in the end, we processed 34 million notes from over 800,000 patients across 158 practices, and those practices used 24 different EHR systems. And I think this is still one of the largest demonstrations of really a multi-site, multi-EHR national NLP project. We found that the NLP pipeline for extracting RA PROs had high sensitivity, positive predictive value, and F1 score when we compared the NLP to available structured data. We found that the NLP was finding a lot more PROs than what were available in the structured data. That's what we expected going into this project. And we also showed in the external validation in the outside healthcare system that it really maintained good sensitivity, lost a little bit of predictive value, but in general, it did pretty well. And so this pipeline is publicly available. If you want to look at it, it's listed at the bottom of this slide. So let me just summarize some of the learnings from this project. I'll start with the challenges. First, data aggregation and cleaning across multiple sites to develop and maintain this NLP pipeline was very resource intensive. Second, there are privacy and security concerns for assembling these large note data sets, and we had to work through many IRB and other issues. And I think that's going to continue to be a challenge as we analyze more and more text data from electronic health records. And then finally, PRO documentation lacks standardization, and it was really important for us, to have a group of clinicians working with NLP experts so that we could point out some of the idiosyncrasies, like, for example, that physicians sometimes copy and paste notes forward, and that some of the data that we were seeing was likely just noise and not meaningful. But I think there's tremendous opportunity. PRO extraction via NLP was feasible in this demonstration project, and it had pretty good accuracy. And for the practices that lack IT infrastructure to collect this information in a structured way, NLP can really add value. And then finally, I'll just say that, some of the methods that we used when we did this project a few years ago have really advanced. Now we have these amazing large language models, GPT and others, and that will almost certainly propel this field forward. I think there's going to be a lot of opportunity. Okay, so the final question, can we develop an implementation toolkit to help practices collect and effectively use RA-PROs? So in the course of, doing all this PRO work over the years, we found, looking at the data, that some practices were just doing this, very consistently, performing at a really high level on the quality measures. Others had lower performance. And we wanted to just go back and understand what the facilitators and barriers were at the practice level. And so we used the consolidated framework for implementation research and went back and did qualitative interviews with practices. And we really took what we learned from there to summarize some of the best practices in terms of collecting PROs. We wanted to highlight case studies of these high-performing practices and develop training materials for people to really optimize their use of PROs. So the final toolkit website, which is hosted by the American College of Rheumatology, is on this slide. And I'll just give you just a glimpse here of some of the information in this toolkit. So for example, in this chapter, we walk people through how to choose the measures that they want to use in their practice. We go through the ACR recommendations and provide links to all of the measures and their scoring so that everything's in one place. In this chapter, we go through the workflows for collecting these RA-PROs. We found that people had, many different ways of collecting this information. Some people were collecting this information on paper and having medical assistants enter that information into structured data. Other people had iPads. Some people were using patient portals. Still others had, very innovative telehealth workflows. And so we tried to create these swim lane diagrams where we outlined typical workflows for each of these data collection strategies. And then we also included interviews with some of the high-performing practices so they could share what they were doing. And then we tried to collate some of the resources that people were frequently asking for. So for example, people wanted access to a lot of these PRO measures in different languages. And, part of the qualitative work was performed during the pandemic, and there was a lot of staff turnover in healthcare. And people said that it was a challenge to continuously train, different medical assistants in terms of how to collect these measures, how to score them, how to enter them. And so we created training guides for practice personnel, including medical assistants and knowledge assessments to, again, have all of these resources in one place. And now that I've shown you some of the content of the toolkit, I'll just tell you a little bit more about some of the qualitative findings that really informed the content of the toolkit. Again, we used the CFIR framework and performed interviews with RISE practices across the country. We performed about 38 interviews across 16 of these practices, and we also interviewed 4 academic medical centers, and then analyzed that data using standard qualitative methods. And in this table, I've listed, some of just the high-level challenges that came up repeatedly in these interviews. And they included things like challenges with the electronic health record, trying to fit this into the time constraints of, busy clinical practices, patient survey fatigue, and so forth. And on this next slide here, I have some quotes from our interviews. In terms of the facilitators of collecting PROs, I think they're the things that we would expect. The high-performing practices had rheumatology physician champions that really stressed the importance of this work and sort of made it a priority and created a culture of continuous improvement. So, somebody said, rheumatologists like to measure how their patients are doing so that they can see their progress. Another person said, we review the data monthly. All the faculty and advanced practice providers are involved, and they either give feedback verbally or send emails with questions, concerns, or ideas. In terms of barriers, I think the thing that came up in basically every interview were challenges that people had with the electronic health record. And here are some examples of the things that people said. It was a lot of customization when we initially built it. I think Epic came out with the joint exam module, but even that required customization. Or the EMR does not have the ability to capture the structured data, so I will input those data manually so that my EMR can capture it for MIPS reporting in the RISE registry. Or I looked into a different EMR, I think the TSI, they have pretty good incorporation of these data, but the cost is prohibitive. And then switching the EMR is a painful process. So much has been written about US physicians and their discontent with electronic health records. But that theme was very strong in these interviews. Rheumatologists did not feel like the electronic health record was supporting them in terms of collecting this information that actually most of them wanted to collect on a routine basis. All right, so let me just summarize some of the lessons that we've learned in rheumatology in terms of our RA patient-reported outcome program. First, having national recommendations and guidelines have really played a crucial role in standardizing the use of RA PROs in clinical practice. Next, the RISE registry's technology infrastructure has enabled us to build a national quality measurement program around this and effectively track this information for patient care as well as for research. Third, the extraction of PROs from EHR data, especially structured data, is possible, but it's incomplete. And many rheumatologists are asking for more supportive EHR software. Next, natural language processing can extract PROs from clinical notes, but it requires significant resources. And finally, education on the use of PROs and peer-to-peer mentorship are needed on an ongoing basis for effective implementation in clinical practice, and we're really hoping that our toolkit will serve as a central repository of materials and training moving forward. So what comes next in this program? Well, here are some of the things that I would like to see. I would like to see us work with EHR vendors to really enhance the systems to facilitate PRO collection and use in RA. And of course, there are opportunities for other digital technologies that are cost effective and might interface with the EHR. We need to study the pros and cons as well as the costs of structured data collection versus using more advanced NLP systems. And then, of course, research the impact and value of these activities for patients. Here's my research impact statement. This research program implemented RA PROs nationally by developing quality measures, partnering with federal quality programs, using a national EHR-based registry to extract PROs, and provide performance feedback and training through the toolkit to rheumatologists. I want to thank AHRQ for their funding, as well as the American College of Rheumatology. They have been wonderful partners all along the way through this research, as well as the members of our research lab. Thank you very much.
So thank you, Dr. Yazdany, for that terrific presentation. So as a reminder to our attendees today, we'll be taking questions after all presentations, so please submit any questions you have using the Q&A panel. Next slide, please. Next slide, please. So we'll be moving on now to our second webinar presentation, which is being led by Dr. Margie Snyder. Dr. Snyder is a professor of pharmacy practice at Purdue University College of Pharmacy, adjunct faculty at the Indiana University School of Medicine, and an affiliated scientist with the Regan Street Institute Center for Health Services Research. She's also the director of mentoring training for the Indiana Clinical and Translational Sciences Institute K-12 program. Dr. Snyder is a pharmacist by training and completed her Pharm.D residency fellowship and Master of Public Health at the University of Pittsburgh. Her scholarship is focused on community pharmacist practice advancement. And now we'll turn over control to Dr. Snyder.
Well, good afternoon, everyone. I am excited to share the work of our team and appreciate having the opportunity to be here. So as you saw earlier, today I'm going to share our experiences so that at the end of this presentation, you'd be able to explain the benefits and challenges of using a mobile application to collect patient-reported outcome, or PRO data, on medication adherence in community pharmacies. So prior research has demonstrated that about half of all patients that take at least one regularly scheduled prescription medication experience medication non-adherence, and that it costs the United States healthcare system in excess of $500 billion annually. Medication adherence measures for cholesterol, diabetes, and hypertension medications are included as Medicare Part D star rating measures. Plans can incentivize community pharmacists to support adherence measure performance through inclusion in preferred provider networks. Community pharmacy teams are well positioned then to collect medication adherence information directly from patients through patient-reported outcomes. Patients visit their community pharmacies 13 times annually, as compared to about 7 visits per year to their primary care physician. And almost 90% of the United States population lives within 5 miles of a community pharmacy. However, multiple pros for medication adherence exist, and to our team's knowledge, there's been no sustained models for community pharmacists' systematic collection and use of pros data for improving medication adherence in their practice. To address this gap, our team decided to spread and scale the use of a technology called Patient Talk from primary care to community pharmacies. Patient Talk is a mobile application that was created out of the LA-NET network. The patient-facing version of the app, which runs on Android tablets, is used to collect a variety of health assessments or PROS data. And then the provider-facing version allows the clinician to review the information entered by the patient and document their response to the PROS if they've identified a problem or what the next steps may be, for example. So we set out to adapt the Patient Talk app for use in pharmacies for medication adherence PROS. In phase 1 of our project, we set out to conduct a pre-implementation developmental formative evaluation to identify potential barriers, facilitators, and recommendations to Patient Talk implementation in community pharmacies, which would then inform the adaptations that we would make to the Patient Talk app and allow us to create a draft implementation toolkit to support implementation of Patient Talk in community pharmacies. Then in phase 2, we set out to conduct plan, do, study, act cycles to refine the implementation toolkit as well as the app itself in order to inform further scaling of Patient Talk in community pharmacies. And then lastly, to conduct a comprehensive theory-driven evaluation of the quality of care, implementation, and patient health outcomes of spreading and scaling Patient Talk to community pharmacies. Our phase 1 research was guided by the Consolidated Framework for Implementation Research, or CFIR, as you heard in the last presentation. Data collection for this phase of the project consisted of site visits to both LA-NET clinics currently utilizing Patient Talk in their practices, as well as to community pharmacies in Indiana, Wisconsin, and Minnesota who were interested in exploring future implementation of Patient Talk. We conducted interviews with clinicians as well as patients across those sites. And all of this work then, again, was informing the adaptations that we would make to the Patient Talk app in the second phase of this research, as well as to allow us to draft an implementation toolkit. In phase two, the initial pilot phase, we measured implementation outcomes as defined by Proctor, such as adoption, acceptability, and feasibility of Patient Talk implementation in community pharmacy practice. The pros that we decided to incorporate into Patient Talk were the Brief Medication Questionnaire, or BMQ, as well as the Merck Adherence Estimator. In the pilot, we positioned community pharmacies to have ownership over the scope of how they implemented Patient Talk, meaning they could choose which specific patient subgroups, if any, or if they wanted to allow any patient walking in to complete the pros in the app, as well as where in their workflow they would implement Patient Talk. However, we asked that they include at least 50 patients in their pilot. The patients that we were targeting then for further follow-up with regards to their actual probes data were those that were aged 50 and above, though that was expanded to 18 and above in the scaled phase, and patients who were using oral medications for diabetes, hypertension, and or lipids. Again, the facilitation plan as well as the toolkit was informed by our phase 1 findings. And we collected data in many ways in the pilot that I'll share the findings with you shortly, including from Patient Talk, administrative records, from the pharmacy's records, our own researcher records, as well as, again, semi-structured interviews. We identified 4 expected barriers in phase 1 to future implementation of Patient Talk. First off, we determined that a lack of existing integrations among technology vendors, such as the pharmacy's pharmacy management system that's used for dispensing medication and claims adjudication, not being already integrated with Patient Talk would present some challenges with regards to feasibility of future implementation of Patient Talk. We also found that participants felt that groups of patients, particularly those who were older adults or perhaps have arthritis in their hands, those who don't tend to physically come to the pharmacy but rely on a caregiver, might be challenged and or feel uneasy about using Patient Talk. Third, we found that it could be difficult to incorporate into pharmacy workflow due to space. Pharmacies often have small waiting areas or shared space where, for example, a patient care room might also be used not just for appointments, but also for a quick pop in for a consultation in private or vaccine administration. As well as staffing could be a concern with regards to the time required, the need for training, staff turnover, which is common in community pharmacies and so forth. And then lastly, data security was identified as an expected barrier, meaning that patients might be feeling some concerns about the privacy of where their information was going once it was entered into Patient Talk in the pharmacy, as well as some concerns about kind of a general culture of a mistrust around technology, and that could limit uptake of Patient Talk by patients as well as pharmacy staff. We also identified 4 expected facilitators. First, we found that pharmacy teams are generally willing to try new things, particularly though if it's going to advance their #1 goal of improving patient care. The pharmacies that we visited emphasized that repeatedly. They're there for their patients. They want to serve their patients, and so if they are bought in that it will improve patient care, they're on board. Secondly, the pharmacy leadership is well respected, and that generally there were strong communication channels identified across the pharmacy teams that we observed, and that we felt that that would be likely to support Patient Talk implementation. Thirdly, as I alluded to in the background, that there are measures of importance to pharmacy teams, such as star rating measures, that align with the impacts that would be expected by Patient Talk, particularly with the emphasis in our pilot of patients with using medications for diabetes, hypertension, and or lipids. And then lastly, we expected, because feedback during the formative evaluation where pharmacy teams were able to see kind of a mock-up of the app of how it was being used currently in primary care. The feedback was that they felt it would be easy to use and that training requirements would be limited or minimal, excuse me. We also identified 14 recommendations in our formative phase of the work. Those included things like ensuring that all pharmacy team members were bought in and engaged to the implementation of patient talk, that we would need to work with pharmacy teams and vendors to result in a well-integrated app with the pharmacy's dispensing system, that we should enable access to the Patient Talk app in various ways, such as through presentation of the tablet by a delivery driver, and having a patient being able to access the application from their own mobile device, and that patients could be able to complete the PROS questionnaires in 2 to no more than 10 minutes. This resulted in multiple resource items that you can see on the slide that were included in the draft toolkit. For example, this included a monthly audit and feedback report in which the pharmacies were presented with information about the number of patients who had used the app in the past month, the percent of those that had non-adherence in their first encounter identified on the BMQ, and a summary of pharmacist interventions completed as a result. In addition, you can see another example of a toolkit item that was provided to the pharmacies was some scripted language. And this was language that they could utilize at the pharmacy itself in order to let patients know about patient talk and to cover some of the points of potential concern that were raised earlier with regards to it being private and an opportunity to share information with their pharmacist in order to have their questions better addressed and any medication concerns mitigated. This could also be included as verbiage that could be adapted for waiting rooms and signage on pharmacy websites and so forth. On this screen, you can just see a few images from community pharmacies who use patient talk. So you can see, for example, some of the signage, some of the posters that were created and hung. The pharmacy in the picture on the left of the screen also has a TV screen that's in their lobby that shares important information with patients as they're waiting. You can see this an example of how it's cycled through some of the advertisements. In the middle of the screen, there is an example where a pharmacy implemented patient talk by having the signage and information kind of at their drive-through, because it's a pharmacy that has a lot of patients using the drive-through. And you can see as well just some examples of signage, some that the pharmacy made itself, as well as staff engaging with the app. So some of the key findings from the pilot phase of the work. So adoption by staff, so really asking patients to use patient talk, was much lower than expected. And what we found was that across the 3 pharmacies, the number of patients who they were able to use patient talk with during their minimum of 8-week pilot time ranged from 11 to 37 patients versus that target of 50 that we had set with the pharmacy teams. Adoption among patients was better, which is not surprising among patients who are waiting for their medications. They really struggled, the pharmacy teams did, with patients when they were coming through the drive-through or were patients that just wanted to get in and out versus if they were planning to wait. We also found that staff were generally satisfied with toolkit items, but they didn't consistently use them. So adoption of resources was minimal. Some drivers of patient adoption, again, other than being there to wait for a prescription, was if they were utilizing patient talk to answer questions regarding a newly prescribed medication that perhaps they were less familiar with, or having some medication concerns at baseline, as well as having a strong existing relationship with the pharmacy team. Unfortunately, though, because we did have low staff adoption that resulted in fewer patients than expected, we believe it was hard to fully assess all of the other outcomes. That said, with regards to acceptability, we found that overall patients spent on average about 6 minutes using the Patient Talk app, and that aligned with our goal from the pre-implementation phase, where the target was 2 to 10 minutes. We also observed that many patients would start the app, but were stopping it before entering their name and contact information, which could also be reflective of concerns around privacy, or not really understanding where their information was going or why it was being asked of them. And we also found that there was a need for improved pharmacists and staff introduction of Patient Talk to patients to really level set the expectations to help enhance satisfaction and promote further use. So again, explaining why was their name and contact information being collected, how that information was going to be used by the pharmacist to help take care of them. With regards to appropriateness, overall, the respondents, or the participants, I should say, viewed Patient Talk as overall appropriate for a community pharmacy environment, but less appropriate for specific contexts, such as at the drive-thru, as I mentioned, as well as pharmacies located within grocery stores where patients routinely are dropping off prescriptions, don't intend to wait right in the pharmacy. They want to go out and shop and do other things. With regards to fidelity, we observed that fidelity was poor in some ways. While pharmacies did ultimately utilize Patient Talk as they planned in their workflow, we found that for each patient encounter, while every encounter should have had a pharmacist follow-on survey, which is the Patient Talk terminology for essentially the pharmacist documentation, logged in the database, that was present for a range of as few as 21% of encounters all the way up to 100%. So this was inconsistent across pharmacies with regards to documentation. Our observations and interviews pointed to a few reasons for why that might have been. One, there were some situations where a pharmacist would review the PROS data and didn't feel there was any clinical action to take, so they just didn't complete the documentation. In addition, we did note some technical issues that were impacting data transfer. And in addition, we found again that staff adoption was just, there was a struggle there with feeling kind of not fully familiar with Patient Talk or what they should be doing, or not feeling fully bought in to why they were having patients use Patient Talk and needed to look at the data that was collected. With regards to feasibility, some pharmacy teams members exhibited some understanding again of where the patient data was going and where they needed to go to review the findings and to follow up on them. There was also a bit of a disconnect in the timing of the collection of the PROS data from patients, and again, review of that data by the pharmacy team. The idea is that would have occurred same day, or within a day or so of the patient completing the PROS. Pharmacy workflow was not heavily impacted. However, again, that could have been due to overall low adoption for pharmacies in pharmacies. Use in some contexts, again, with waiting patients was more feasible. And while we observed that unscheduled contacts with the pharmacy's assigned research team member or practice facilitator decreased over time, this was sometimes associated with less adoption over time. So fewer kind of nudges from their facilitator was associated with less adoption over time. So all of these implementation results really led to the following considerations for the scaled phase of the project. So we considered and ultimately decreased the patient age threshold to 18 years. And we had changed, instead of asking for patients to fill the targeted medication that they were answering questions about, as a 30-day supply to encourage repeat encounters within our pilot period. We said it could just be any medication that they fill within 30 days. And both of those changes were made to try to encourage further adoption with more patients. It was also suggested that perhaps pharmacies could be provided with a brief data summary from the pilot. So for example, noting that it was taking patients on average about 6 minutes to help promote staff adoption, because there were some concerns by the staff that it was still taking too long. And with regards to facilitation, one of the considerations that came out was to increase from one launch visit at the pharmacy to 3 in close succession within the first week of launch, and then going back in after I believe it was a week, and then monthly thereafter, and to also add in weekly or twice weekly webinars for the first month to help with adoption and feasibility. And then lastly, it was considered that instead of utilizing a separate tablet for the provider or the pharmacist to access the PROS data and complete their documentation, that they could use an Android emulator that's available free of charge to download onto the PC to help save costs. We also compared the expected barriers and facilitators that we identified in our phase 1 formative evaluation with what we actually observed in the phase 2 pilot. And we found that all expected barriers that I noted that we found in phase 1 aligned with what we actually observed in phase 2. And on the slide, I say 3 of the 4 expected facilitators, but upon more reflection, I would say really 2 of the 4 fully aligned because while pharmacy teams leadership was respected and there was strong communication, we still observed that that really wasn't enough to promote staff adoption, that there were still a lot of challenges with staff feeling kind of not bought in to the purpose of implementation of patient talk in their pharmacies. In addition, we found that while star rating measures, again, they incentivize pharmacy teams to help improve medication adherence, it really wasn't enough to encourage or really promote further adoption by pharmacy teams of patient talk. And it's also important to note that we were unable to implement half of those 17 recommendations that we identified, such as enabling access to patient talk outside of the pharmacy. We weren't able to do that. So patients did have to complete the app on an Android tablet physically at the pharmacy. And in addition to that, for one example, was we were unable to integrate the patient talk app with the pharmacy's dispensing system. So the patient was manually entering information that would have already been available in the pharmacy dispensing system had we been able to integrate from the outset. So with regards to next steps, the scaled implementation phase, so the last part of our phase 2, is actually wrapping up as I speak. However, thus far, our findings do appear similar to the pilot phase, with several challenges around adoption still noted. It's also important to note that we've observed poor sustainability. So 7 of the 12 pharmacies included in the scaled phase actually dropped out early after 1 to 4 months of implementation. And we also observed poor penetration, meaning that only 1 pharmacist per pharmacy was actually logging the follow-on surveys or the clinical documentation. So it wasn't spread across the entire pharmacy team successfully. We're currently wrapping up data analysis, both quantitative and qualitative, and synthesis. And in addition, we are proceeding in the next couple of weeks to do a short pilot test of the app that is integrated with a pharmacy management system. So we've been able to work on that as we've been spreading and scaling the non-integrated version. We wanted to go ahead and address that limitation. And so we'll be completing a pilot of an integrated version of the app. So we've learned a lot from this research so far. First off, I'll say I think this work really highlights the importance in implementation research of completing that pre-implementation formative phase. We found that our experiences in our implementation pilot aligned quite well with the findings of our formative research. And so therefore, we really, in hindsight, we wish we could have better mitigated those barriers and been able to fully implement recommendations. And I think it also highlights the questions that need to raise and discussions that need to happen if you have, for whatever reason, like we did, a situation where it just wasn't possible to mitigate all the barriers or implement all the recommendations. So how does one move forward ideally? Secondly, I think our work really points to the importance of having a very clear scope of work when you're going to implement technology that's created by an outside vendor or outside partner. So while from the outset of this project, our plan was, as recommended in the formative phase to implement an integrated version of the Patient Talk app, there was a disconnect with the Patient Talk vendor, and they were unable to do that in a manner that was, timely and cost effective. And that's why it took us several more months to now have a version of an integrated app ready to do a brief pilot with. And along with that, then the non-integrated app actually requires some text write-in, which is different than the original version of the app that we observed in our formative phase. And so that didn't come to our attention until we got to implementation. And that change in the display definitely impacted acceptability in the pilot phase. And so it really does point to the need also to allow time from adaptation of the app to do some formal usability testing prior to putting it out into the field. And then lastly, we certainly also just identified the need to plan on even further resources and pilot testing of our facilitation plan to improve adoption. As I mentioned, we really observed minimal staff adoption beyond the pharmacist champions, who were the ones who documented every encounter in Patient Talk. It's also important to note the timing of all of this. So this project launched in 2019 with the initial plans around the implementation pilot phase to be in 2020, and that ended up getting pushed back. But we struggled with recruiting and retaining pharmacies, during the pandemic and post-pandemic, as this really felt like just one more thing for them to do, particularly with not having any compensation tied to it. Pharmacies are feeling very strapped, as I'm sure many of you have seen on the news and are familiar with. And then lastly, it also demonstrated that there were challenges with pursuing this multi-practice-based research network collaboration, so across 4 total networks, without completing pilot work together to allow us to help just explore our own team dynamics and the way we would work together, and how that might have also made some of the challenges that we experienced in our pivots to this remote environment during COVID, as well as some of the challenges we faced with the vendor and how that would impact things moving forward. So in summary, this is my research impact statement. So implementing a mobile application in community pharmacies for the purpose of identifying and resolving medication non-adherence is challenging and requires extensive pre-implementation work to mitigate barriers and promote adoption by pharmacy teams and patients. As I wrap up, I absolutely would like to thank very much AHRQ for their support of this research, as well as the many, many, many individuals, colleagues, learners involved, and absolutely the pharmacies who were willing to partner with us in spite of all the challenges with COVID and other things. So thank you.
So thank you, Dr. Snyder, for sharing your experiences in this very interesting application of patient-reported outcomes. So for the audience, please feel free to submit any questions you have using the Q&A panel at this time. We'll be moving on now to our final presentation of the webinar, which is being led by Dr. Stephen Dehmer. Dr. Dehmer is a senior research investigator and health economist at the Health Partners Institute based in Minneapolis, Minnesota. His research includes the economics of disease prevention, often focused on cardiovascular disease, diabetes, obesity, and cancer, and health services research more broadly. He's led many studies using microsimulation modeling, including the decision analyses conducted to support the U.S. Preventive Services Task Force recommendations for aspirin that were published in 2016 and 2022. His research also includes the investigation of patient-centered outcomes, such as in orthopedic care or in the use of care coordination for patients with complex medical needs in primary care. So we'll now turn the control over to Dr. Dehmer. Thank you.
Great. Thank you so much. It's a tremendous pleasure for me to be here with you today, presenting on behalf of my colleague, Dr. Leif Solberg. And today I'm going to share about our experience with patient-reported outcomes in orthopedic care in a study funded by AHRQ. Hip and knee replacement are among the most common elective surgical procedures performed in the United States. There are about 1 million hip and knee replacements each year in the U.S., and rates of these surgeries have been projected to double by about 2030. Hip and knee replacements are expensive procedures and can cause significant life disruption during recovery, yet the eventual benefits are perceived to outweigh the costs. And perceived is sort of the operative word here. With many clinical interventions, we have objective measures to assess effectiveness, such as blood pressure control, infection rates after vaccination, and so forth. And though hardly alone in this regard, orthopedics faces challenges with appropriately measuring successful clinical outcomes, as they are difficult to fully ascertain from external observation or measurement alone. Now, objective measures exist, such as strength, gait, and range of motion, but these are likely to be inadequate with respect to a holistic assessment of patient perceptions and physical functioning. Therefore, going on several decades now, the orthopedics profession has been deeply invested in developing patient-reported outcome measures, or PROMs, as a means to obtain valid and reliable assessments of patient outcomes, coming directly from patients themselves. There are several PROMs that have been validated and standardized for hip and knee patients. Common PROMs for hip include the Oxford Hip Score and the Hip Dysfunction and Osteoarthritis Outcome Score for joint replacement, sometimes called Hoos Jr. And common PROMs for knee include the Oxford Knee Score and the Knee Dysfunction and Osteoarthritis Outcome for joint replacement, also known as Coos Jr. Now, these measures are obtained by relatively short survey instruments with 12 questions for the Oxford and hip and knee scores, and just 6 or 7 questions for the Hoos and the Coos. All of these surveys ask about pain, which is often asked in a specific situation, such as while climbing stairs, while walking, or at night while in bed. The surveys also ask about hip and knee function, how hip and knee function may limit activities of daily living, such as being able to rise from sitting or bend to the floor to pick up an object. Responses to the survey questions can then be run through a scoring algorithm to calculate an overall score measuring hip or knee functional status. Now, to be useful, PROMs are typically collected at multiple time points, such as prior to surgery, and then at specific intervals after surgery, such as after 3 months and 12 months. Additional studies have been then conducted to understand how much the change in these PROM scores translates to clinically meaningful improvement for patients, which can then be used to track progress. While not yet universal, PROMs are being widely collected and used in orthopedics. For more than a decade, the American Academy of Orthopedic Surgeons has maintained a PROMs registry for hip and knee procedures nationwide. As of 2021, the registry contained PROMs for 2.8 million knee and hip procedures performed on 2.6 million patients. These PROMs were reported from more than 1,200 clinical sites in all 50 states. And due to some upcoming policy changes, collection of PROMs may accelerate rapidly soon in orthopedics. Starting in 2025, CMS is expected to require reporting of PROMs for hip and knee procedures conducted in hospital settings. This is being done in part for quality improvement purposes, with plans for public reporting of PROMs improvement data in 2027. To encourage compliance, hospitals not reporting PROMs for at least 50% of their eligible hip and knee procedures will face financial penalties. So this leads to a natural segue of some of the challenges with PROMs in orthopedics and other domains as well, for certain. And first on the list is response rates. Because PROMs are self-reported and require survey completion, patient engagement and participation is necessary. When considering these new CMS rules for reporting, strategies that improve response rates may be front and center for many hospitals and care systems. Moreover, PROMs have no utility, whether they be for aggregate reporting, quality reporting, or for individual patient care, when they're not collected at all in the first place. Another challenge is with patient understanding of PROMs. If they have a score between 0 and 40 on the Oxford Hip Score, or between 0 and 100 on the Coos Joint Replacement Score, what does that mean? And what does it mean if they improved by 10 points? And how does that compare to other patients like them? Patient understanding and clinical meeting are of particular concern for using PROMs at the point of care. Surgeons also have a relationship with PROMs, and it shouldn't be assumed that surgeons always trust or know how to use PROMs in their clinical practice. Both patient and surgeon factors may contribute to how PROMs are used or not used in clinical care. And finally, there's a vision and ambition for using PROMs in orthopedics to achieve better patient outcomes and better overall value with orthopedic care. but it shouldn't be assumed that there are easy wins in this regard. With this study, we sought to address each of these challenges in some capacity with our research. So that's what I'd like to be sharing with you today. Specifically, I'll be sharing findings from the PROMOTE study. This study was born out of a partnership of orthopedic and care delivery leaders collaborating with research. Specifically, this study was conducted at Health Partners, which is a large integrated care system in Minnesota, and its affiliated research and orthopedics partners in Health Partners Institute and TRIA Orthopedics. There were already initiatives in place routinely to routinely collect PROMs for orthopedic patients, but this study and its partnership represented an opportunity to evaluate strategies to enhance the use of PROMs in orthopedic care. The overall vision was to innovate the use of PROMs in the pursuit of the triple aim, to achieve better patient outcomes, better patient experience, all at a lower cost. Or in other words, using PROMs to drive better value in orthopedics care. Now, the study comprised of multiple components that include mixed methods and evaluation of randomized and non-randomized interventions. The study had 4 specific aims. The first aim was to identify any patient-preferred outcomes or patient contextual information that would be useful in care planning for patients undergoing hip or knee joint replacements. The second aim was to test the effect of PROM's survey response rates when using technology-enhanced outreach, such as through text message reminders. The third aim was to assess patient outcomes and experience from making PROMs available in the electronic health record during patient care. And the fourth aim was to test the impact of providing surgeons with reports comparing their PROMs and cost outcomes relative to their peers. So following from these aims, there are 8 key findings from the PROMOTE study that I would like to share with you today. To start, we found that text messaging can improve response rates to PROM surveys. For our patients, the existing process for collecting PROM surveys involved an emailed invitation with email reminders at days 5 and 10 following that initial invitation. And as you might imagine, survey responses tend to come in quickly at first. We found over 50% responded in the first 7 days, but then rates start to taper off after that. So we designed an experiment to improve response rates among those who had not responded yet by day 7. Specifically, non-responders after 7 days were randomized to the standard email reminder protocol or to receive an additional text message reminder on days 7 and 12 following that initial invitation. Among those receiving the additional text message reminders, 51% responded to the PROM survey versus 35% in the group that did not receive the text message reminders. So this was a modest but significant improvement that could be one tool in the toolbox for increasing completion rates for PROM surveys. This is especially relevant given the upcoming CMS reporting requirements. It may be appealing because text message reminders can be automated and low cost once they are set up. A second key finding, and I think very interesting one, is that patients told us that they prefer their own personalized outcomes over standardized orthopedic PROMs to track their progress. On the right of the screen, you can see examples of the outcomes patients identified for themselves. Being able to walk without pain or discomfort and pain relief in general were the most commonly identified outcomes. But there are other outcomes that patients identified as goals, such as the ability to sleep through the night, to return to work, or to return to sport. More than half of our survey respondents told us that these outcomes mattered more to them than how much they improved on a standardized PROM score, like the Oxford Hip and Knee scores I described earlier. Nevertheless, about 4 in 10 also thought that the standardized measures were useful. Moreover, most patients wanted their surgeons to know about these personalized goals. Collecting these personalized goals may sound challenging, but we've been able to do it. We've been collecting these personal outcomes for our hip and knee patients for several years now since implementing. Our next and related finding is that personalized PROMs are better collected by open-ended questions and that they can change over time. Based on our prior key finding, we added an open-ended question about what patients saw as their most important outcome or result they hoped to get from their surgery. And we found that over a 6-month period, that 91% of patients were able to identify such a goal prior to having their surgery. 3 months after their surgery, 54% of responding patients, mostly or completely, said they achieved their personal outcome goal. And then 86% of respondents identified a new goal that they hoped to achieve. In other words, patients' goals and expectations are not static. they can change over time, and surgeons can expect that if patients achieve their initial goals, they're likely to move the goalpost, so to speak, to strive for something else. To explore opportunities to streamline the collection of personalized PROMs, we had 2 reviewers independently compare each patient's full open-ended response to a list of the 17 most commonly identified personal PROMs. And the reviewers determined that in more than 8 of 10 cases, the open-ended responses would have lost some or a large amount of meaning if they had been remapped to one of the common personalized PROMs. In other words, personal outcomes are generally quite personal and are better collected in open-ended form rather than selecting from a multiple choice list. The 4th key finding was that patients wanted to engage in shared decision-making with their surgeons. However, making PROMs, whether standardized or personalized, available in the electronic health record is not sufficient to ensure that they'll be used. Specifically, 79% of the patients we surveyed told us that they wanted to engage in shared decision-making after their surgery. Moreover, they identified a wide range of issues affecting them post-surgery that they wanted to discuss with their surgeon. Those issues summarized to the right included things like noting that they had stairs inside or outside of their house or their homes, concerns about infections, living alone, and worries about pets that they had to care for. However, when we integrated the standardized PROMs and the personalized measures into the electronic medical record, we found that these data were accessed by surgeons at fewer than 1% of orthopedic visits. Given the very low use of PROMs in the electronic health record, we talked with surgeons to try to understand why. And we found that surgeons saw PROMs as being more useful in aggregate reporting than for individual patient care. Furthermore, they saw logistical issues that impeded the use of PROMs at the point of care, including too many clicks being required, the displays of PROMs data not being particularly useful for showing to patients, and a common concern of not having enough time to incorporate discussions of PROMs into their visits. Surgeons also worried about how well patients understood PROM scores and expressed their own concerns about the validity and reliability of these scores. The surgeons, though, did offer some suggestions for enhancing the utility of PROMs at the point of care, which included using them earlier in the care process, such as before a patient has even decided to have surgery, making the PROMs easier to access, and developing graphical displays to facilitate patient engagement in their outcomes. Key finding number 6 is that patient factors are more strongly associated with improvement in patient functional status reflected in PROM scores than surgeon factors. Specifically, we found that a substantial portion of the variation in PROM's improvement, as much as 40 to 50%, can be explained by a relatively short list of preoperative patient factors, such as the patient's age, sex, race, BMI, and their baseline functional, mental, and physical PROM scores. Moreover, after accounting for patient factors, we found very little, even less than 1% of the variation in PROMs could be attributed to the patient's surgeon. I think there are several takeaways from these findings. Number 1 is that prior to performing a total hip or knee procedure, it may be possible to predict the expected benefits of that surgery with surprising accuracy on the basis of some easily knowable patient factors alone. Number 2, at least within a high-functioning orthopedics group, it appears to matter very little who your surgeon is in terms of the functional benefits of a hip or knee procedure. This seems to speak very highly about the reliability and professionalism of orthopedic surgeons, which I think should be reassuring to patients. And number 3, it suggests that when comparing surgeon performance on patient outcomes, it is important to account for differences in the patients that they serve. This may speak to the concerns we heard from surgeons about trusting PROMs, because in aggregate, they may speak more about the difference in the surgeon's patients than the differences in the surgeon performance. That is, if patient case mix is not accounted for. Key finding number 7 is that variation in surgical cost-related outcomes is more associated with the surgeon than the patient. So when considering a couple thousand procedures, we found that moderate variation in implant costs, ranging from about 5 to 35%, was associated with who the surgeon was performing the surgery. We found an even greater association, on the order of 65 or 70% of the variation in procedure time, which is another contributor to surgical costs, to be associated with the performing surgeon. In contrast, minimal variation in these outcomes was associated with the preoperative patient factors that we considered. So I think the key takeaway here, combined with the findings from the last slide, is that if you are pursuing high-value care, opportunities are likely greater to engage surgeons on reducing the variation in costs rather than on patient quality outcomes. Finally, based on a small experiment, we found that providing surgeons with performance reports on their PROMs and cost outcomes did not improve these outcomes. What we did is we implemented an intervention that distributed reports every quarter, personalized to each surgeon, comparing their PROMs improvement and cost-related outcomes to their unblinded peers. This was an idea that actually came direct from the surgeons themselves, who believed that the competitive nature of orthopedists would drive interest in learning from each other and improving, especially if they saw themselves as performing below average compared to their peers. So we designed the distribution of these reports to be every 3 months to give enough time for patient outcomes to be measured and to establish a feedback loop in which surgeons might make changes and then be able to see the results in a subsequent report. Ultimately, this did not work, but I think that this is likely more due to practical than conceptual reasons. Distrust in the data was an underlying concern. Part of this can be attributed to that variation in patient outcomes being highly correlated with patient characteristics, and this is something we try to control for. But for the cost outcomes, we observed significant challenges in obtaining reliable cost data from administrative reporting systems. These shortcomings could conceivably be overcome with further concerted efforts, though. Our intervention itself was also relatively weak in that we only sent out the reports and then discussed them at quarterly staff meetings, but no additional actions were taken specifically to foster conversations or adaptations or learning among the surgeon colleagues. So to recap, the collection of PROMs in orthopedics will likely be accelerated by CMS policies, which will broaden the exposure to the types of challenges that we tried to address with this study. Our findings on how to improve response rates with the use of text message reminders may be of particular interest in this regard, at least to begin with. Further, although standardized PROMs have a role in aggregate reporting and comparisons, we found clear indications that patients have their own personal preferred outcomes and goals, and they want surgeons to know about their personal goals and issues, and these can even change over time. Finally, and relatedly, there's strong interest in using PROMs to enhance individual care and shared decision-making. This may be the area of greatest challenge, but I also see it as the area of greatest opportunity for improving patient outcomes, experience, and the overall value that they have with their orthopedic care. If our team was to summarize the impacts demonstrated by the PROMOTE study, we would emphasize that when forming a real partnership between a care system and researchers, and by genuinely listening to and engaging patients and surgeons, it's possible to learn and improve the approach, collection, and the use of PROMs to improve orthopedic care. Excuse me. Finally, and not least, I want to recognize the critical financial support for this project from AHRQ, the administrative leadership of Dr. Dehmer, and the scientific leadership of principal investigator Dr. Leif Solberg. The multidisciplinary and diverse PROMOTE study team is listed here, and each of them have made important contributions to this work. Thank you so much for your time and for the opportunity to present. I look forward to any questions you have. And please also feel free to reach out to me after today with the email address on the screen. Thank you so much.
Thank you, Dr. Dehmer. And thanks again to all of our presenters for their really informative presentations. So as a reminder, please submit any questions you have for any of our presenters using the Q&A panel. So this concludes the content portion of our webinar, and we have a few minutes left for questions. As mentioned before, you can type them into the Q&A section of the WebEx portal. Although we may not be able to get to all of them today, we'll provide responses to all questions in writing. You'll receive an email once these responses are available. Now, we do have some already in the Q&A. So one of them is how, and please feel free, any of the panelists, to chime in here. How did you adapt your survey instruments that you used for patients with vision loss, limited English proficiency, or literacy or health literacy limitations?
I'm happy to start, Chris. I can share that the design of Patient Talk is designed to optimize the use of the technology for patients that have some of those considerations. Just a couple of examples. The responses, as as selected light up as they go so that the patient can tell what response they're on. And in addition to that, there's a speak aloud function. So if a patient has any challenges with vision or literacy, we provided the pharmacies with individual earbuds that patients could use as well to have responses read to them, questions read to them. So those are just a couple examples.
Thank you, Margie. Jinoos or Stephen, do you have anything to add for surveys that you administered?
I can just add that in our research, talking to rheumatology practices around the country, they had, all different kinds of methods for addressing this issue. So some of them just acknowledged that they didn't have the resources to actually administer PROs when patients were not able to complete them, either because of language or literacy issues. On the other end of the spectrum, there were practices that had medical assistants read the information to patients or, had family members helping patients fill out some of these PROs. I think what we found is that there was a lot of heterogeneity and that for the most part, people were not using technology that facilitated, some more innovative ways of reaching the patient population. Like, for example, technologies that might read questions aloud or that might assign questionnaires in languages beyond just, Spanish, for example. So I think there's still a lot of work actually to be done in this area.
Good point, Jinoos. Thank you.
I can briefly say for our study, for those surveys, we often have phone options with multiple languages. But I think the more interesting question is in terms of collecting the patient-reported outcomes in orthopedics care, especially as that's expanding. I think the question is a really good one. And I'm actually not familiar with all the strategies they use for patients within our care system, but I know among them is having an iPad available in the waiting room or at the clinic where the patients can fill it out and they can potentially get help with somebody at the time. But I think there'll be a need for other strategies as well if these are used more broadly, millions of patients.
Thanks, Stephen. So we have another question for any of the presenters. If you have knowledge of and an opinion on this, could you please share what methods you think are best for collecting PROs, such as emailing a survey, giving the patient a device with the survey loaded, providing a QR code, etc.? If you'd like to comment, that would be great.
I can start, Chris. I think probably the most important thing that we learned in our qualitative studies was that there was, definitely not a one-size-fits-all approach. I think that for most rheumatology practices, and the ones that we talked to largely were community rheumatology practices, either sort of a single specialist or sometimes multi-specialty groups. They really just did not have the IT infrastructure to develop sort of elaborate EHR integrations and things like that. And so most people were just using sort of simple, low-tech workflows. Probably the most common thing was just to collect the information on paper, have the MA score the sheet and enter that into the EHR. And then there were people who were using iPads that were not necessarily integrated with the EHR, but would at least automate the calculation. Of course, there were people that were doing, more advanced things using digital applications and, some people using the patient portal. I think there's a lot of room for innovation in this area, but I guess advice I would give for people that are just starting out is just to be realistic about the resources that are available in the healthcare setting and to just start small, even if that means like starting on paper or with a simple iPad survey and then building from there. Because it takes time to, make more sort of sophisticated integrations, especially with, digital apps and the EHR.
Yeah, I will completely echo Dr. Yazdany's comments. I agree. We really observed in our work a need for flexibility for many patients and pharmacies, kind of that kiosk model or, Android tablet model of having the patient complete the pros right there in the pharmacy as they waited for prescriptions was fine. However, we did hear loud and clear that many patients as well as pharmacies, particularly, at least qualitatively, we were told that this was more a bit of the younger generation would have preferred to have been able to just download the app themselves to their own mobile device and complete the pros electronically that way. And then we absolutely also heard a bit about this would have been easier on paper. And then even in terms of workflow, part of that depended as well on systems that the pharmacy already had in place. So for example, in our scaled phase, one of the pharmacies already routinely uses an iPad for checking patients out, including through the drive-through. So patients in the drive-through are very used to having a tablet be handed to them in the car, and they take, answer a few things, then hand it back. So that pharmacy was very comfortable, and their patient population was very comfortable with having then the Android handed to them, and they would just take a lap around the drive-through and come back and hand the tablet back when they were done answering the pros. So I think that flexibility is key.
Margie?
Yeah, I would echo multimodal is certainly helpful. I don't know if there's any one best. The other thing I would note is I think it's helpful when asking patients to complete these that if they get something back from it, it increases the intrinsic motivation to do it in the first place. And this is in orthopedics, I think they're not quite there yet. There's more opportunity. But when you're using the pros in a way that the patients value, that's going to enhance interest in taking the time to complete it by whatever mode is used.
Thank you. We have a few individual questions here. So the first one for Dr. Yazdany, what features would ideal supportive EHR software include to overcome the incompleteness of the patient-reported outcomes data collection and extraction that you mentioned?
Yeah, thank you. So I've given that a lot of thought. One of the things that we need to overcome is that currently rheumatologists just have no easy way of entering structured data regarding PROs and the EHR. And that impedes, I think their workflows and also just the ability to track the information in some kind of visualization over time and be able to really share that with patients in a way that facilitates shared decision making. And so they've devised all these creative workarounds, such as, entering PRO values as a vital sign or a lab result or in a nursing flow sheet. I think that is problematic. What we really want is an EHR that's designed to support chronic disease management and that includes some of these RAPROs as part of its foundation software, especially because these are nationally endorsed quality measures, and we have evidence that, using these measures to treat to target actually results in better patient outcomes. So for me, the EHR would have structured data that's in a very intuitive place that could be entered. It might actually connect to a digital app easily, and then have, a nice visualizations or dashboards that the doctors can use to share with their patients. And also, I think really importantly, access for the patient to be able to also track their outcomes. I mean, they're filling out all this information, and I think it would just be wonderful for there to be an easy way for them to track their own progress over time. I feel like that would be like basic functionality in my mind that the EHR should provide.
I'm seeing lots of claps from the audience here, so I think lots of people are agreeing with you. Margie or Stephen, would you like to comment on ideal supportive EHR software by any chance?
I mean, I would really just echo, what was said. I think anytime there's an opportunity for, I love the idea of the patient being able to track their own. I completely agree with that, as well as to make it easy with visual tools and other things for the clinician to track, as well as, I guess, offer decision support, so as data are coming in to help guide. I think in some ways that would have been useful if we could have added that in for the pharmacists. Have some guidance, and we had training modules but not built in, not integrated decision support.
I don't have much to add to those great comments. The integration and enhancing utility are really key.
Margie, if you could have done one thing differently in your project, what would it have been?
Oh, that's a great question, and absolutely, it would have been a more kind of more intentional, I guess, discussions with patient talk at the beginning to make sure we really understood the scope of work and what we were saying. Because as again the project unfolded, it became more clear that we weren't on the same page with, what did we mean we meant when we said integrated with the pharmacy dispensing system exactly. We wanted information to pre-populate in to reduce the patient burden and having to type in any information, particularly with medications. You can imagine patients really struggle with the names of their medications and, how to spell it. And so that would have been much simpler for it to come over. So absolutely having those conversations more in depth on the front end is a key lessons learned for me.
And Stephen, we have somebody asking about where they can get more information about the PROMOTE study.
Yeah, well, the slides will come out, I think, later. So there are citations at the bottom of the slides where you can find out about different things I talked about. But I'll do a plug for AHRQ here. I was just pulling up to confirm that if you go to the website and search for the study, maybe search for Dr. Leif Solberg, SOLBERG. You'll see the study. It's got all the final report and there are 9 publications thus far, and I think we've got 3 more in the works that should be coming. So that's a great place to see about the study and published findings.
Thanks for that plug about our website. It's at digital.arc.gov, and you can find project profiles on all of our projects, including the one that Stephen just mentioned, which is under Dr. Leif Solberg's name. So please feel free to visit digital.arc.gov. And Amal, maybe you can put that into the Q&A portion so that people can see that, please. And Dr. Yazdany, one more question for you. You mentioned large language models. Are you now experimenting with them at all to extract data by any chance? I'm curious.
We are. I have a computer scientist, AI postdoctoral fellow who's working with me, and we are in the process right now of using the RISE registry clinical notes and trying to, organize and extract EHR data, including PROs, using some of the newer large language models. And, we've done some early experiments just with data at UCSF, and it's just interesting that the newer large language models like GPT really outperform some of the older tools that we were using. So they're very, very powerful, even with very little sort of tuning and training in the healthcare setting. And so I think there's just a lot more to come in this area. Currently, EHR clinical notes are sort of in a lockbox, and I think these large language models are suddenly going to open up just many new areas of research. So it's a really exciting time.
Yeah, I'm waiting to see some applications coming into us about experimenting with large language models and patient-reported outcomes.
Good to know.
So thank you once again to all of our presenters. We're going to bring up the slide now about how you can obtain your CME and CE credits. For those interested in obtaining those credits, please visit the URL shown on this slide. You'll select today's webinar, which will be indicated by the date and title to claim your credits. You'll have 14 days to claim your continuing education credits. I also want to note that upon exiting today's webinar, AHRQ is fielding a brief evaluation, and we really hope that you'll complete this survey to share your feedback with us. It's really important to us. We do pay attention to these surveys. Thank you all once again, and thank you for all the attendees for this webinar. It was terrific. Have a great rest of your afternoon.